It's my pleasure to introduce our next speaker, who is a colleague of mine, Dr. Nikolaos Papamitsakis. Dr. Papamitsakis is an associate professor of neurology at SUNY Downstate Health Science University and director of the vascular neurology program, fellowship program at Downstate. He graduated from the University of Crete School of Medicine in 1991, completed his neurology residency at Mount Sinai Medical Center in 1998. Then went down to his vascular neurology fellowship training in Oregon Health Science University, and then followed by Henry Ford Hospital in 2000. Since then, he has been a practicing stroke neurologist, actively involved in resident and student education, as well as clinical stroke research. He's board certified in neurology, vascular neurology, neuroimaging. His clinical interests include acute stroke management, stroke prevention, and the common cause of stroke. Today, he's going to talk to us about the update from the International Stroke Conference. Nick.
So good morning, and thank you very much for this kind invitation here. I've been following this stroke symposium for the last few years, and I'm very honored that you invited me also to talk today. And the title, as we had discussed, is New Paradigms of Stroke Care, and I'm going to talk a little bit closer. I'm going to talk about a few trials that have been showcased in the recent International Stroke Conference. But obviously, this is not a comprehensive presentation, regarding all the new information in stroke, which is obviously a field that's continuously bustling with new trials and information. Regarding the disclosures, for whatever it's worth, since probably the Supreme Court doesn't care about financial disclosures, I don't have really anything pertinent. We might talk about, as you see, about some unlabeled treatments of ischemic stroke. So the outline of this presentation is going to be about trials that I think they are going to change the paradigm in how we treat stroke patients. And in particular, we're going to talk about the latest large trial regarding tenecteplase, TNK, that was just presented. Obviously, you heard already from Dr. Wang what is done here at Maimonides, which basically has switched the treatment from alteplase to TNK, but that's going to give, I believe, another let's say, boost to this particular treatment. Then we are going to talk about these two trials in the vascular thrombectomy, the ANGEL aspect and SELECT-2, regarding treatment of what we call large strokes, strokes with large core, which I think also will probably change the paradigm. Then hopefully we have some more time to talk about another trial from China. Actually, most of the trials are from China, which gives an idea how advanced actually this country is, and the possibility to enroll a large number of patients and complete trials that we probably just can dream in the US. But the other one we are going to talk is about the comparison of antithrombotics, dual antiplatelets versus thrombolysis in small non-debilitating stroke, the ARAMIS trial, and also talk about platelet antagonists in acute stroke treatment, the RESCUE BT2 trial of tirofiban. And then maybe a few things about treatment of small strokes, lacunar strokes, this British trial, the LASSI-2, and a few things about monitoring of atrial fibrillation in patients with small vessel and large artery disease. And if we have some time, there's going to be a bonus because actually, exactly at this moment, the European organization stroke conference is taking place. And I was able to get some of the trials that were presented yesterday, some initial information that I'm going to, to discuss. And right as we speak, I think they're keep on presenting until tomorrow. You are obviously an audience that are well familiar with the importance of stroke. Although the death rate in the US, that's from 2020, is around the fifth more significant cause of death. I mean, probably the rates have gone down a little bit, but as the population ages, they still are in a significant level. Worldwide, it's actually the second more significant cause of death. So it's an important issue. And when we talk about treatment, we look at all types of stroke types. And this is just a classification here that you are also well familiar, from large artery, lacunes, cardioembolic, cryptogenic, etc. And as Dr. Wang also mentioned, this is the trial that really changed everything almost now 20 years ago, leading to approval of TPA as treatment in 1996, and has revolutionized the stroke care. If you are interested to learn a little bit more about this, the path to the TPA, the initial trials, and eventually the approval, that's a nice book by Dr. Zivin, who unfortunately was one of the pioneers who used the TPA in stroke patients and did the first trials, dose finding, etc. Unfortunately, he passed a few years ago. And also, I don't want to dwell on the criteria. You are familiar with indications, contraindications, which actually change as time passes, because probably in the initial trial, we had kind of stringent criteria to minimize complications of this particular treatment. And now, we kind of have a little bit loosened up. Obviously, we follow, let's say, very strictly, imaging before treatment, blood pressure control. The time also, although we have an expansion of the time window, and we try to look at techniques that give us a tissue, what we call a tissue window, and not only a time window. And that's typically the paradigm that you're familiar. The patient comes, get the CT, probably TPA if there's an indication at that point, and then vascular imaging along with advanced tissue imaging for patients who might eventually go for intervention with that's a stent retriever there. And we have various techniques, as you also probably are familiar with, in trying to evaluate the patients who come in with even on the plain CT to see if there are what we call early ischemic changes. That's the so-called aspect score from Alberta that gives points to particular areas in the MCA territory, as you can see here. This is the insula, this is the caudate, internal capsule, lymphonucleus, and areas in the MCA territory. With a score of 10, if there is no early change, if there are changes, the score decreases, and if it's a score, let's say, less than 6, that might mean more than 1/3 of the territory involved, and that could be significant regarding obviously hemorrhagic complications and outcomes. And just this is another example of the advanced imaging with CTA in the top panel here, and the CTP, and just have the Tmax and the CBF that predicts actually the stroke in this left posterior MCA territory in a 24-hour CT. And the whole idea of doing, the thrombolytic treatments and the vascular interventions is really to preserve what we call the ischemic penumbra, which is the brain that has not infarcted and to minimize the expansion of the core, as you can see here, which if it's left untreated, is going to grow and obviously cause significant disability and death. So that has been the idea with all of these things that we are trying to do. And another thing, just to finish this brief introduction, is that the sooner you treat, the better. This is from the original TPA trial, that the odds ratios, as you can see here, decrease as you go into the 3-hour window, the 180 minutes. Nowadays, obviously, I mean, that's another meta-analysis of the various alteplase trials that show benefit of alteplase in many scenarios, including 3 to 4.5 hours, even in some cases over 4.5 in older patients and in various NIHSS scores. And nowadays, with the results of the ICAS-3 that I think you've heard, and other trials, we know that you can treat, and have good overall odds ratios, even beyond, the 3 hours, 4.5. But then when you get now to the 5-6 hour window, then the ratios diminish. So despite what this, illustration of The Economist many years ago, mentions here, is that the FDA is not really asleep, because it's very hard actually to get approval for new medications in stroke. So apart from TPA, I don't think that we have another approved medication. All the basically neuroprotective agents, I hope that minocycline eventually pans out to be beneficial, but there have been some papers reviewing 1,000 let's say trials of interventions in stroke, including multiple neuroprotective trials that have been negative. And obviously some people have been also complaining that the drugs have a higher burden to cross compared to the device that have been approved kind of easier. That's just an old slide showing the Mercy device, which we, I guess, don't use at all. Dr. Wang can affirm to that. So moving on to go to the main part of the talk here, talking about TNK, which has been evaluated now for years. I guess cardiology might not use anymore TNK, as you heard, but when they use it in the last several years, they use it instead of alteplase, and it has some benefits. It has a higher fibrin specificity, and maybe benefits recanalization and bleeding compared to alteplase, and has also a longer half-life, and it's also a very easy medication to give compared to the TPA. As you know, TPA needs to be given as a 10% bolus and then infusion over 1 hour. This one is just a bolus in 5 seconds or 10 seconds, and it's done. So it's going to obviously make the life easier of multiple healthcare providers, including the nurses. So again, this just shows how the evolution has been regarding the management with either IV or IA thrombolysis, with some of the landmark years, 95 or 96, the approval by FDA was the alteplase. The ICAS-3 was published in 2008, and then the several of these endovascular trials were published in 2005 that made endovascular treatment a staple of acute management. And a little bit later, we had trials that showed benefit even in the more extended time window with endovascular approach. Regarding though TNK, there have been over now 10 years efforts to show the benefit in stroke patients. From this small trial that I put here in 2012 by Mark Parsons in Australia, to a few other trials, including the NOR test back in 2017, which did not show benefit because it was designed to show superiority. So this was not achieved, but eventually, actually last year, the Canadians published this trial, the ACT, using actually 0.25 milligrams per kilogram. I believe that's the dose that you use here at Maimonides, and showing benefit. So in this conference, and this is just, whoever is interested to read the older papers from the NOR test from 2017, showing that there was some benefit, but especially the higher dose of 0.4 milligrams did not have good, an optimal side effect profile. And regarding tenecteplase in patients who are treated with endovascular intervention, this trial, the Extend IA, also from Australia, showed benefit back in 2018. So based on this, the recommendation, the latest recommendation in the guidelines that you are also probably all familiar with from 2019 are that you could give it in patients who are eligible to get endovascular intervention, and also that when they talked about the tenecteplase in the 0.4 milligram per kilogram, they said that there is no good evidence, but it could be considered. So not obviously a very strong recommendation. So the latest that we have is, and I'm going to show you here, is the trial for Canada from last year that used 0.25 milligrams per kilogram that showed a benefit. And, I guess we'll have here multiple, let's say, tables and figures, etc. But the point here is that when you see down here the modified ranking score, you have a very good outcome in both tenecteplase and alteplase. And given that particular design of the trial, the so-called non-inferiority, it seems that tenecteplase should work. And actually, in different guidelines, the Canadian guidelines from 2019 and the European from 2021, it is considered as an alternative. And that's just the safety profile, which is also very similar, including the cases of angioedema, which were around 1% for both, and the hemorrhage around 3%. So the trial that we've seen in the recent conference that I think probably will push the envelope more towards, the more universal use of PNK is this TRACE-2 trial that was done in China, and the design is the following. They enrolled patients with stroke, again, with basically more or less the same criteria like for that we use for alteplase. They had some limitation in the NIH score. They didn't want to include, very low NIH or very high NIH stroke scale patients. And they use either tenecteplase up to a max dose of 25 milligrams versus alteplase with a max dose of 90, as you know. Again, these are pretty similar to what we use for alteplase. They exclude patients who had decreased level of consciousness, more than 2 in the NIH scale. And basically the outcome was the MRS, which the modified ranking is really the major outcome as most of the stroke trials in the last few decades. And also had secondary outcomes, including quality of care, Barthel scores, etc. And the safety, obviously, it's a symptomatic hemorrhage, which used the so-called ECAS-3 criteria. within 36 hours and 90 days, along with other hemorrhages, systemic hemorrhage, and overall mortality. The sample size was around 1,400, and they tried to have a sample size that would lead to statistical significance. And as I said, they are able to achieve that, maybe the population, but also obviously the willingness of patients to be enrolled in trials there. This just shows here, how the two treatment arms were allocated, and they had a few patients who dropped out or who couldn't complete the study. They were lost to follow, but overall, it was a very well, designed trial. Regarding the baseline characteristics that are also well balanced, as you can see here, and I'm presenting lots of tables in this talk, but I just want to show you that all of these trials were very well done. They were scrutinized, and the results we should believe, I think. Now, regarding the outcomes, the scores at 90 days were very similar, maybe a little bit better in the tenecteplase arm, but not statistically significant, as you see. And the same is here when you see the different modified rankings in the either intention to treat or the per protocol arm. Regarding the hemorrhages, they were also very similar, around 2% in both arms. So if one would summarize the results of this trial, is that it appears to be non-inferior to alteplase when it's used within 4.5 hours. There is no difference in safety profile, and obviously can be an alternative to TPA. Now, moving on to the next part of the talk regarding thrombectomy. Obviously, you've seen maybe these clots that Dr. Wang and all his associates removed from the vessels. That's a stent retriever here with excellent recanalization, TICI 3, TICI 2C, etc. And the various devices that they are available now. The stent retrievers obviously are a staple, but you have all the suction devices like the penumbra here and others. And obviously, these have significantly improved in the last decade, and they continue to improve. And that's why nowadays we talk about recanalization with the first pass, which means that you just go once and the clot moves out. And I think overall, and correct me if I'm wrong, it might be around 50%. And then eventually, maybe if you do 2 or 3 passes, you can lead to recanalization rates of 90% or more. And that's not an exception. Most of the interventionists, or the experienced interventionists, achieve that. So as I mentioned before, in 2015, we had a number of trials from Europe, US, Australia that showed that for LVO, but we are talking now LVO in the anterior circulation and in the early time window, the endovascular treatment is beneficial, but these patients did not include large strokes or patients with what we call a large core. And if you remember the aspect score that I mentioned earlier, they excluded for multiple of them, apart from the Mr. Clean, but multiple of them, they excluded patients with more than 1/3 of the MCA, which means score of 6 or 7 or less. And then if they did advanced imaging with CTP or MRP, then they excluded patients with large volumes, more than 70 cc's or 50 cc's, either as you measure it or when you had this rapid, automated system measuring the core. And that's just a summary of all the trials. I think I'm missing the top here, where it's the various studies from Mr. Clean to Rebascat, Thrace, etc. The results were, overall, when they did a meta-analysis, so-called Hermes consortium meta-analysis, that the outcomes were around 46%, leading to good results in those patients, with a number needed to treat around 2.6. So 2.6 on average patients to be treated to have a very good outcome. Beyond the 6-hour window, there have been a couple of trials. Back, as I mentioned, 2018, the Dawn and the Diffuse 3, which the first one had up to 24-hour window, the second up to 16 hours window, with very similar good outcomes. And we are talking about good outcomes as patients who had an MRS of 0 to 2, around 50%. And this just shows what happens when you have a small kind of core with an aspect score, which is, might be 9 or 10, but with an MCA occlusion here that is confirmed on the angiogram, and after intervention and very good recanalization, you get a small stroke. If the core is larger, like in this particular case here, when you have an aspect score of, let's say, less than 4 or 5, with significant abnormalities on CTP with a large core, as we call it, even with recanalization, you end up with a large stroke, in this case also with hemorrhagic conversion. So there have been several trials now, and only one of them was up to the ISC published. This is the Rescue Japan limit trial, where they used evaluate patients with large cores. As you see here, the aspect score, you probably won't see it very well, but it's a score of 3 to 5 with NIHSS of score more than 6. And again, they used as an outcome a little bit of the good outcome in these trials was considered to be an MRS of 3, so evaluating people who are able to actually walk. Because the fact is that if you have patients with large cores, it's very unlikely probably to have excellent outcome without any deficits at all. So you increase a little bit that window. But overall, this trial showed a benefit of probably around 20% compared to no treatment. And in this conference, 2 trials were presented that I'm going to try to review here for you. The Angel Aspect from China and the Select 2 from multiple countries, US, Europe, Australia, and New Zealand. And there are 3 more trials that are still going. This Tension, Laced or Last, and the Tesla, which actually was going to be presented to the meeting, but somehow the abstract got withdrawn. I'm not sure if it's still going to be presented in the future meetings. So this is the first one. Was actually just published in New England. At the time of the meeting. Again, this particular trial evaluated patients with low aspect score, so you have lots of early changes on the CT, or with a core infarct, as you evaluate with advanced imaging of 70 to 100 cc's. And the design was basically a one-to-one randomization for treatment with endovascular treatment and best medical management versus just best medical management. And they used, again, patients, adult patients, they put a limit in 80, similar to the original NIH trial. They try to avoid pre-existing disability. So the MRS on presentation was 0 to 1. And there was also a limit on the NIH up to 30. Sorry. Okay. So again, there were 20 provinces in China that participated, and I guess they are able to enroll patients even during the COVID pandemic, and the enrollment was completed in 2022. Again, here, if we want to see the baseline characteristics, they were, more or less very similar. There were a few differences, but overall they are balanced. And these are basically the efficacy outcomes, showing that the endovascular group had overall a better modified ranking scale score. You see some patients here with a score even of 0, which is sometimes hard to fathom, but none in the medical management group. And although maybe the median is similar in both groups here, we have an MRS of 4, you have a benefit in the endovascular group, which was statistically significant. So this brings to mind, obviously, the hemicraniectomy trials, where there was a significant benefit in patients treated with hemicraniectomy. But obviously, many of these patients who were treated ended up having significant disability. And that's always an issue that needs to be discussed with the family and the patient, if possible, prior. Because some people might not want to end up, more disabled, and they prefer to be dead. But obviously, that's many times a personal decision. Same thing here with, the MRS between the both groups, and the, safety outcome here, that's in the lower part of the table, are kind of similar. Symptomatic hemorrhages were higher in the endovascular group, but not statistically significant, but any other intracranial hemorrhage, so asymptomatic also, were higher in the endovascular group. But as you also know, we really worry more about symptomatic than, any incidental hemorrhage. Also, subgroup analysis favored overall the endovascular treatment, as you can see here. And just to talk a little bit about the limitations, obviously, a smaller percentage of these patients received intravenous thrombolysis, so the medical group did not have that particular advantage. Sometimes urokinase was actually used, which we don't use in other areas in the world. And no patients were enrolled with aspects more than 5, and infarct volume 7,200, because patients who had high aspects and a large infarct volume were infrequent in this cohort. And obviously, they did not enroll patients over 80. And, again, as with all the Chinese trials, there is this argument that, maybe it applies more to Chinese, where you have maybe higher intracranial artery stenosis, or you might have some genetic changes like this P2Y12 limited response to antiplatelets. But I would say that, generally speaking, looking at this very well-conducted trial, in patients from China with a large infarction due to LVO in the anterior circulation, the vascular therapy within 24 hours, we had better outcomes. You had higher ICH, but not symptomatic, as I mentioned. So the next one that we are going to talk a little bit is the SELECT-2 trial, which was also presented and published just now in New England. And again, the idea is that the large core patients have been underrepresented. As you know, many interventionalists, they want this advanced imaging, tissue imaging before they decide to do an intervention. So they want, the CTP and, want to have smaller core and significant penumbra. And there is a meaning to do, obviously, this to evaluate these patients because the natural history is poor when you have a very large stroke. And, maybe by treating them, you can avoid, obviously, death or complications from herniation or a hemicraniectomy. There have been some reports over the years that people who got this endovascular intervention, they had less kind of hemicraniectomy compared to patients who did not. And the way they used aspect score or this calculated core volume. They used rapid AI, but also other techniques. But just the point here is that when you have a low aspect score, you might have different volumes in the automated system. So this one, both of them, they have aspect scores of 4. I guess it's hard to see it, the slide there, but the core is 70 cc's or so in the first and 170 in the second. So in this particular trial, again, it was a phase 3 with blinded outcomes. All these patients, they had obviously CT and advanced imaging with rapid AI. And again, the outcomes were the MRS and safety outcomes is symptomatic ICH. They were planning to enroll around 560 patients, and they had interim analysis. But once this other trial that I mentioned to you, the Japanese trial, Rescue Japan Limit, was presented, the DSMB eventually led to stopping the trial. The enrollment was pretty good in various sites despite also the pandemic. And again, this is how these patients were treated. The baseline characteristics were also overall matched. And the outcomes are again here with this sliver of in the second part here. So let me go back. Representing the patients who had the MRS of 0 in the endovascular thrombectomy, but there were none in the medical treatment arm. So this was statistically significant. They calculated that the number needed to treat was around 5 to have a good outcome. Again, with a good outcome, we are talking about patients with an MRS of 0 to 3. So it's not patients who don't have deficits. And they also evaluate the patients from 0 to 2 with a little bit of a higher number need to treat versus 0 to 3. Same thing is for benefits were shown in the secondary clinical outcomes. And regarding the safety, again, the symptomatic hemorrhage was very similar. It was around 0.6 in the endovascular arm and 1.1 in the medical arm, with similar mortality cases, percentages. And there was more early neurological worsening. The possibility was that the edema after the treatment, what we call the reperfusion injury in the endovascular treatment arm, might have led to this. And again, this is just a summary from the paper. Now, this was beneficial in various, sizes of ischemic core in patients who had core less than 70, but also in patients greater than 70, which was around, 2/3 of the patients, and another subgroup of, more than 100, which was around 20%, and even in patients with a core of 150. But these numbers were actually very small. You see here 44. Regarding the side effects, I mean, there was a significant reperfusion in all of these cases. There were obviously complications, some complications on the arterial side, but also vascular injury, dissection, and perforation. And a few similar regarding the subgroup analysis. Yeah, I guess that's the paper tables. So just to summarize here, in patients who have LVO in the arterial circulation and low aspects, so large ischemic core, the treatment with endovascular thrombectomy improved functional outcomes, either independence, which consider an MRS of 0 to 2, or ambulation 0 to 3. The hemorrhage was a little bit higher, I think, but overall infrequent. There were access complications, and overall this trial confirms the results of the Japanese trial and also the Chinese trial that I just presented. Overall, obviously, the outcomes are not as good as with a smaller core, infarctions. If you get into the patients back from the 2015 trials, the Hermes consortium, in the late window, the good outcomes was around 50%, 46%, and in this trial it's around 20 to 30%. But that also again might switch the way we are treating these patients, and also the way we are maybe evaluating these patients, because if you might not need to prove that there is a small core in a particular patient, you can just look at the CT. Maybe you don't need necessarily advanced imaging. And just as a point here, advanced imaging in many times, it looks like it minimizes the patients who are going to be treated with endovascular intervention. So moving on to another trial that was presented here in patients who might not fit for endovascular treatment using a platelet inhibitor, the tirofiban. This is just the protocol that they published last year. And obviously, the issue is that several patients with LVO, maybe nowadays after, if we change the paradigm, as I mentioned, might be less, but certainly we have patients with distal stenosis, medium vessel diameter, and distal occlusions that are not treated necessarily with endovascular intervention. So these patients, as well as patients who they are not treated with IVTPA, maybe there would be some other method to treat those. So in patients though who, as I mentioned, who don't have a large or medium vessel occlusion and are ineligible for IV thrombolysis, maybe they arrived after 4.5 hours. Patients who receive but they have neurological deterioration or who don't improve. So these are all patients that many times we see in our practice, and always there is a thought what to do best. Obviously, you can try to improve perfusion, try to hydrate, bring their head down, keep the pressure up, etc. But these patients might not do so well. This is a 2B3A antagonist this tirofiban, which is highly selective. It gets reversible and blocks platelet aggregation. And it has been evaluated in a couple of previous trials in the SETIS and SATIS. We did not show benefit of stroke outcome. They had outcomes at 1 week or 5 months, but maybe some of these results were diluted because they included large or medium vessel occlusion strokes. They include cardiogenic, and they didn't include patients who failed to respond to IV thrombolysis. So this trial was trying to focus on this particular patient, see if we have an additional treatment. So these were the inclusion criteria. So having patients treated within 24 hours or less than 96 hours if there is ischemic progression when the NIH score increases by 2, or patients with IV thrombolysis with early neurological deterioration or non-neurological improvement. So either the NIH stroke increased by 4 or does not decrease by 2 after IV thrombolysis. So in these patients, that was really the randomization schedule. They used 0.4 micrograms per kilogram per minute for 30 minutes and then an infusion up to 48 hours in the tirofiban group. And they use oral placebo versus intravenous placebo in the aspirin and oral aspirin. And then they evaluate them up to 90 days. And in this particular trial, you had overall a benefit. If you look at modified rank of 0 to 1, which is around 6.9%. And overall, the tirofiban group appears better with kind of similar rates of hemorrhage, although obviously there were more hemorrhage in the tirofiban group. So one conclusion that one can make, and obviously this probably needs to be evaluated in larger trials, because we did have similar trials of intravenous kind of antiplatelets in the past that did not eventually show benefit. That in this particular population, patients who had a disabling stroke without large or medium vessel occlusion within 24 hours showed an improvement in the MRS of 0 to 1. And the intracranial hemorrhage rates were low, but still higher compared to tirofiban. So one more, I think I'm going to present is the issue of what do we do with patients who have small strokes, not debilitating strokes. And you might, obviously, the definition here is that the mild stroke is with NIH equal or less than 5. And this is the majority of the ischemic strokes in the US. And overall, the benefit is kind of unknown. I mean, from the beginning of the thrombolysis era, there was the observation that people who have small strokes, or they might appear to improve a little bit, but not return to baseline at the beginning, they eventually might have significant deficits. So there was obviously always a tendency to try to treat these patients. But when a trial was attempted, the so-called PRISMS trial, evaluate patients with these types of small strokes within 3 hours of onset, the use of TPA did not show benefit. Now, this trial was stopped early due to issues with enrollment and some other administrative issues. But the fact is that, it did not show benefit, thrombolysis. At the same time, since 2016 and after, we have the CHANCE and the POINT trials that showed benefit of dual antiplatelets in patients with a small stroke when they are treated within 24 hours. And the idea is to try to evaluate dual antiplatelets versus thrombolysis. The PRISM trial did not use DAPT, it used obviously only aspirin. So this is the design of this RAMES trial, having patients with NIH of less than 5, and using clopidogrel 300 milligrams as bolus, and aspirin 100 milligrams, followed by 75 of clopidogrel, versus patients treated with IV alteplase with a typical dose. Again, they try to exclude patients who had disabling deficits. If they had, let's say, a point in vision, language, or neglect. Some of my colleagues might obviously disagree, and they say that if you are even mildly aphasic, that's going to be, possibly a debilitating stroke. So there can be some discussion regarding the inclusions here. Again, they exclude patients with significant disabilities, history of ICH. And the primary outcome, again, is MRS 0 to 1 at 90 days with the typical secondary outcomes. And they used, again, a significant sample size that they were able to achieve. This is the allocation here with balanced baseline characteristics. And these are basically the primary outcomes that there was a difference of 2.3%. So you had patients who were treated with DAP that did, had, as you see here, higher MRS of 0 and 1 together compared to the alteplase group. And secondary deterioration was a little bit more in the alteplase group, again, maybe because of the reperfusion. And bleeding was also higher in the alteplase group. And these are just some of the secondary outcomes. So again, in patients who are from China with minor not disabling stroke, dual antiplatelet was non-inferior to intravenous alteplase. So one should consider that, since it's an undertaking to treat with IV TPA patients. So if you have the options just to do dual antiplatelets in this particular subset, I think maybe that's something that might change also the way we practice. I was going to talk a little bit about secondary prevention, but we want to leave also some time for questions here. And what did you say? Also, you want to do the question during the break? Okay, so I'll move on, and maybe I'll give you the bonus. So, okay. Yeah, the bonus. So anyway, so a few things about secondary prevention, in particular in small vessel strokes. This is just the design of this particular trial, the LACI-2. And the idea is that lacunar strokes are an important part of, or small vessel strokes of, the total stroke population. You have significant cognitive impairment in those patients. And we think that they are due to small vessel disease, but it could be also what we call the intrinsic endothelium problem of the small vessel that leads to stiff, leaky vessel walls, impaired dilatation. And there is this rationale that maybe one could use these inexpensive agents, cilostazol or Plital, that our vascular surgeons use quite a bit of peripheral vascular disease, which is a phosphodiesterase inhibitor that sustains prostacyclin, CMP pathway and stabilize endothelium, and also isordil or isosorbide mononitrate, which is a nitric oxide donor, and it is used quite a bit by our cardiology colleagues. And in this particular trial, they had this so-called 2x2 factorial designs. They include patients older than 30 with an MRS less than 3, had evidence for small subcortical lacunes. They didn't have a time from onset of stroke to randomization. And they use basically cilostazol 100 milligrams versus no cilostazol and isosorbide 25 twice a day versus none. And then they, although it was an open label, the evaluation was kind of blinded or masked with MRS, the MOCA scores, some of the quality of life scales, and did also an MRI at 12 months. And they wanted to see if this could be feasible and could be tolerated by the patients, and what the outcomes would be regarding recurrent stroke, MI, cognitive impairment. And that's basically, how they were trying to design it. The pandemic had an impact in them. They were going, to reach the target, but eventually they end up with 363 patients. So they were able to get close to the target, and one could say that they were able to have patients who tolerated. They had 90 patients on isosorbide alone, 91 on cilostazol, and 91 on both isosorbide and cilostazol. There were hemorrhages, which were kind of in the less than 2% target, was 1.1%, and also death in 1%. The baseline characteristics were similar, and eventually these are the results showing that there is some benefit regarding the composite outcome in patients treated with these agents, and in particular in patients treated with isosorbide regarding the recurrent stroke or TIA, or the patients were treated with isosorbide again in addition to cilostazol. And again, the dependency was a little bit, better in patients, or there was a tendency in the patients treated with isosorbide as well as in patients treated with both. Overall, the treatments in this particular trial were tolerated. There were no significant safety outcomes or drug interactions. It looks like isosorbide alone reduced recurrent stroke and cilostazol reduced dependency, but the combination reduced both recurrent stroke and dependency. And it's obviously an open trial, so there are limitations. And overall, this kind of drugs that improve an endothelial function might reduce recurrent stroke and dependency after lacunar stroke, maybe also improve vascular cognitive impairment. And a larger trial is in preparation that hopefully will give more answers. I was going to mention a little bit about the stroke AF trial, the 36 months, but we might skip it just to go straight to the bonus. And we can talk maybe a little bit in the... So this is just from yesterday's, because I think you're all familiar with the Arcadia trial. I think you participated here at Maimonides and us at Kings County. And the trial was stopped early a few months ago, and these were the results of the, I mean, that's very preliminary information that I'm giving you here, but more or less, we have these patients who have the so-called ISUS, embolic stroke of undetermined source. So people who look like they have cortical strokes, maybe cardioembolic, but we haven't proven that they had, let's say, AFib, intracardiac clot, or other reasons that could be an indication for anticoagulation. But they have what we call atrial cardiopathy. For example, high prom-BNP, larger volume of the atrium, or P waves on the EKG. So based on this criteria, they try to evaluate these particular patients with this type of cryptogenic stroke. with apixaban, 5 milligrams or 2.5, depending on the patient, twice a day versus aspirin. And the interim analysis after more than 1,000 patients were included, but not when the target was reached, showed that there was no efficacy or harm, and the trial was stopped. And these were the results that they present. So the trial was really, really negative. And then there is this one that was, I guess, just published also in New England at the same time, regarding do you anticoagulate early or late after a cardioembolic stroke due to atrial fibrillation? I mean, in the guidelines we have this 1-3-6-12 rule. I think in the European guidelines in particular, that you are, if there is TIA, you can anticoagulate after 1 day or the same day. If it's mild, 3 days, moderate 6, and larger strokes, you wait for a couple of weeks. But based on this trial, it looks like that you can anticoagulate sooner. But apart from all of these new paradigms, I just want to tell you that our job is, either primary physician or, stroke neurologist, is that, we need really to, in order to minimize the stroke burden for our populations, we need to battle this horsemen along with a few others, because as my favorite stroke neurologist or major neurologist, Fisher, said that if a patient gets a stroke, his physician should be at fault because stroke is such a preventable disease. So I think that's, I have some conclusions also, I guess. So obviously, IV thrombolysis is going strong. Thrombectomy is becoming more and more widespread. I believe it will become even more with these large core trials. And, hopefully we have new approaches in stroke prevention, and there is also lots of work to be done. I mentioned the medium vessel occlusion patients, etc. So thank you for your patience with all of this data that we presented.
Great. Thank you, Dr. Papamitsakis, for your comprehensive review. A lot of updates, exciting, and a lot of future directions. Controversies, I'm sure, as well. So there are some questions in the audience. Eric.
You mentioned that there was cognitive impairment with the lacunar stroke. Are we talking one single stroke or status lacunaris?
I mean, obviously, not with a single lacunar stroke or the tiny thing that you might see, let's say a thalamic stroke, that the first one that somebody has. But the problem with all of these strokes is that they do recur. And, when you have, a significant white matter disease, I mean, you don't need to have even the so-called Binswanger's encephalopathy, with all of this. This has a burden on the patients. So we want to, I mean, they are small strokes. They have kind of less, let's say, deficit overall compared to the larger strokes. And maybe, but if they do recur, they cause a problem. And I think nowadays, even the paradigm of treatment of Alzheimer's is changing, because many of these patients, they really have significant vascular underlying problems. And we try to focus on the vascular, let's say, prevention for those patients to improve overall their outcomes.
Was the dementia more subcortical dementia or no data on that?
I don't think that they mentioned anything in that particular trial. But
Thank you.
Many of them, when you have all of these extensive diseases, subcortical, as you point.
Yeah, I have a comment. Just follow the question. I think localization is key. As we're real estate agents as a stroke neurology, location. So besides the size, and I think that not only cortical, subcortical, but also particular region, hippocampal or thalamic regions may potentially be more prone to cognitive impairment as opposed to, say, brainstem. Other questions in the audience? Can we check? So for those taking silosyral, is it contraindicated to take other vasodilators such as nitroglycerin or sildenafil? Yeah.
People do use those, Yes, anything that improves, obviously, the nitric oxide might be beneficial, but I don't think that they had any particular interactions in that trial. But as a matter, if you can ask the vascular surgeons, for example, or any practicing neurologists, many of our patients they do take, the Pletal, as we call it, silostazole here in the U.S., and occasional nitro.
I guess it's the mononitrate is the one that has vasodilator effect, not the cholesterol. So that's cholesterol is more of an antiplatelet, right? So that's the other property to the combination therapy. Any other questions? I do have one question, which has been puzzling me, I think many other interventionists, in terms of treating those low aspect score patients. So even though the number needed to treat is, say, less than 5 and maybe 5 to 7, depends on the population and score aspect. But I can't stop noticing that to achieve the benefit we're saying between 19 and 38% of functional outcome improvements or 20 to 30%, we have to carry the other 50% of patients did not improve at all on the other end. Number one. Number two, we have to carry the burden of near 50% intracerebral hemorrhage rate, even though symptomatically it's less, and didn't differ very much. But that's a huge price to pay to carry these milder patients. So what are the criteria potentially you think would be to select with this patient learning population potentially will be actually generating most of the benefits without the other end of the patients, right? No matter what you do, they will not do well.
I mean, that's a valid point. On the other hand, again, I can bring you, I mean, it's not the exact equivalent, but it's the hemicraniectomy patients in malignant MCA stroke. I mean, they are not going to do also all of them very well. And as I think alluded there, when you do this kind of treatments in patients who have severe disease, you trade, death, let's say, to disability. I mean, in these patients, there was a benefit, as you saw, even in the, a very minuscule, percentage had, let's say, an MRS of 0, but I mean, that's kind of expected. But I believe that, in the end, there is, eventually a decision that the family, if the patient, but many times the patient obviously cannot give us, an informed, let's say, consent or decision in this setting. But if they accept, the risk of keeping somebody alive with, with significant disability, because as you see, the median was, the MRS was 4. I mean, there were obviously some, much better, but it's not like these people, they did spectacular. I mean, that's the reality. But my question is, do we really need, if we are going to treat all of these patients, do we really need advanced imaging, for everybody that we do? Because, the fact is that we don't also know what always this advanced imaging, let's say, mean. Is it, does it always predict, accurately what is the ischemic core, what is the, let's say, the hemorrhage risk? I mean, in general terms, we do see, these kinds of things, but there are patients who surprise us. So if you don't want to, to leave any stone unturned in a particular patient, you might want to go that route. And, obviously there is the other question, do you have enough interventionalists to be on call and, deal with, every single stroke patients, resources, etc. But that's another, I think, trial to be, or, evaluation to see if this is really, it makes sense, to do it.
I agree. I think, to me, there's no real one size fits all. I don't think we should have across the board, so to speak, the cutoff, whatever, because every single patient is different. their anatomy and their collaterals are different. Right? Their philosophical beliefs are different too. So the same modified ranking scale 4 or 5 may be acceptable for one patient, but totally non-acceptable for the other. So we should put, there are a lot of factors that will phase into the clinical decision making. Yeah, so I think to me as an interventionalist, I know some people don't give up fusion and CTA altogether. They just go for the CT aspect score and go. To me, I still pretty much believe on CT perfusion, selecting out those rapid progressors, as I mentioned. Sometimes they come in that there's interval that in between the CT scan showing and perfusion or showing deficits. So those are the patients that can oftentimes be futile, but there may be a few saves here and there. We don't really know how to tease those out at this moment, but to me, that's always. Otherwise, if you do everything all by aggressiveness, then you'll be burned. You'll have cases, you have complications. How many complications do you have to endure until you backtrack? So that's the other thing.
Sure.
We probably should train more interventionists. So get your fellowship going and more turn up more.
Start this year, no?
2024, if anyone is interested. We have neurointerventional fellowship available. Anybody interested? Good. Thank you so much, Dr. Papamitsakis. Thank you.